starting momentarily. All right. Well, welcome to the Palliative Care and COVID-19 seminar series. Good morning, good afternoon, good evening, wherever you are. This week, we're going to have a very special webinar on the topic of suffering alone and grief and bereavement. This webinar will be recorded and will be available shortly after completion. My name is Dr. Stephen Connor. I'm Executive Director of the Worldwide Hospice Palliative Care Alliance, and I'm moderating today's session. This is number 5 in a series of 10 webinars in a project on palliative care and COVID-19, developed jointly by the International Association for Hospice and Palliative Care, the International Children's Palliative Care Network, Palliative Care in Humanitarian Aid Situations and Emergencies, and the Worldwide Hospice Palliative Care Alliance. The objective of the series is to provide globally relevant information and guidance to civil society and UN organizations, policymakers, administrators, healthcare providers on palliative care in the context of the COVID-19 pandemic. The webinars are all accompanied by briefing notes that are written by experts from around the world. These briefing notes are available in the globalpalliativecare.org website. And the webinars and slides are available on the WHPCA website. We're very grateful to the contributors of this series and to today's presenters for accepting our invitation to participate in this collaborative project. They've all been involved in the development of briefing notes on these topics. This webinar will feature 3 15-minute presentations with time at the end for questions and answers. We will also have reflection from Diane Gray, a parent with palliative care experience, who will share some reflection on the topics and presentations. You can submit your questions through the chat box, and Shelley Anderson and Kate Jackson from WHPCA will be condensing and reading them to the speakers. Please send your questions to everyone, not just the panelists, when you submit. So the first 2 speakers are going to be presenting on the psychological and social implications of physical isolation for patients and families during the coronavirus pandemic. First speaker will be Professor Dr. Gary Roden, who is Professor of Psychiatry and Director of the Global Institute of Psychosocial Palliative Care and End-of-Life Care at the Princess Margaret Cancer Center at the University Health Network at the University of Toronto. And they're going to be doing kind of a joint presentation. So we'll segue right into the second speaker, who is Dr. Chitra Venkateswaran, who's Professor and Head of the Department of Psychiatry and Palliative Care in Trivandrum, Kerala, India. She's also Clinical Director of MIHAC Foundation and on the board of the International Association for Hospice and Palliative Care. So we will start the presentations now, if you'll give me just a second. Great. By the way, there are no conflicts of interest from any of our panelists and speakers today. So Gary, over to you. Gary.
Very much, Stephen. I'm very pleased to be part of this symposium and to be able to hear from all of the speakers about the whole spectrum of problems that are related to coronavirus. I think this is quite a unique problem for the world, or maybe it's made us aware of many of the problems that we share. There's more attention, I think, interestingly, to mental health in this pandemic than we've often seen with many other conditions, perhaps because the whole population is affected. People in the general population, healthcare workers, and patients and families who are suffering from the virus. By the way, in province where I live, 15% of all cases are in healthcare workers, actually. So this is very much a shared problem. And maybe this slide The picture on this slide maybe illustrates that, in that the physician in this picture in China was the first one to report the risk of COVID, and he also later became a patient and died as a result of this disease. So we have this very unusual phenomenon in which there's been this rapid community spread. There's been almost 300,000 deaths in the world so far. Unfortunately, many of those deaths occur for people in separation and isolation from their families. Even in the hospital, they've been distanced from healthcare providers who are now wearing masks and keeping physical distance. Many people, infected or not infected, have had to face the threat of not being able to get cancer treatment, or certainly not being able to get admission to an intensive care unit. The symptoms, and we're going to hear later from Chitra and other people about how to manage them, are highly distressing, including breathlessness, agitation, and confusion. And I think what we're seeing is the need for what people are calling emergency palliative care. That this is such a contrast to the whole trend in palliative care, because we've been very much engaged in the whole idea of early palliative care, where we have time to plan how one is going to live, where one would be at the end of life, the nature of care. And now we're seeing this happen in a rapid sequence where there's little time for advanced care planning, for closure, and many people do not have access to palliative care and face the end of life alone. Next slide. And I think there's been some attention to the fact that although this is a global phenomenon, we have speakers today who are from many parts of the world, but people in the world are not equally affected. People who live in population-dense settings, in impoverished settings, are more likely to become infected, to have less access to food and medical care, and to die. And generally in the past, we've thought of differences between low-income and high-income countries, and the pandemic has highlighted that. But even within high-income countries, we're not all equally affected. So I think it's highlighted this problem in health equity that's always existed, but I think it's shown a light on it. And of course, the financial consequences and access to medical care are also not equally distributed. Next slide. And so one of the things we've observed, I think, is that on one hand, the problems in integrating measures in public health, in clinical medicine, and palliative care, I think we've seen the problem that's come from the lack of integration in many countries. On the other hand, I think the epidemic and the pandemic has collapsed the boundaries between them. So we're seeing unprecedented cooperation and collaboration. We have public health leaders, clinical leaders, palliative care leaders now all working together in the same way. And this is something we need to think about in terms of how to plan for the future. This kind of coordinated planning has usually not occurred. At the same time, the public health measures have created this problem of social isolation. And social support, human connection is probably as an important factor in managing disease as any of the other treatments that we provide. And this pandemic has robbed many patients of that, patients and families of that, both before they become ill and when they become ill. And so we need to think in many creative ways about how we can provide that kind of support. Next slide. So I just want to introduce this psychological construct that not everyone thinks about, but is really fundamental. Attachment security refers to the sense of connection to other people. It's something to do with how much support we actually have, but it's also a psychological state, to what extent we feel connected. There's been a lot of research demonstrating from something called terror management theory, and some of the research that other people are doing, that we're also doing, to say that attachment security and social support is really the fundamental resource that people need in order to manage death anxiety. So when we talk about death anxiety, we need to intrinsically think about how much support there is around the individual. It's certainly bolstered by connection with close others. And in many cases, unfortunately, what we're seeing is this kind of escalating death anxiety with social isolation and progressive disease. I don't think there's been a literature that's emerged yet, an empirical literature on the quality of dying death, but we know that all of the features of coronavirus are contributing to factors that cause a poor quality of dying and death. Deaths in the ICU, death without advanced care planning, poor control of physical symptoms, and unrelieved death anxieties. All of these, we've shown in other research and other people that these are the largest contributors to poor quality of dying and death. And we're going to hear about bereavement later this morning, and I think this is one of the downstream complications, is the difficulties in bereavement that come from these kinds of problems at the end of life. Next slide. And we don't ordinarily, we talked about these silos between palliative care, clinical medicine, and public health, but actually government and leaders in medicine and public health play an important role actually in the population in controlling the pandemic, but also in individual and personal psychological well-being. We know that countries in which there's been a consistent and reliable communication from government and public health leaders and healthcare providers in whom there is trust has enhanced the sense of community and provided a greater sense of mastery over this problem of COVID virus. And of course, countries where this has been absent have had, where it's present, have had the most effective infection control measures. So what I've tried to speak about in these few minutes is this kind of overview for us to broaden our perspective, to think about how we're going to treat the individual patient and the individual family, how we're going to manage a healthcare system in which healthcare providers are distanced from the patients, where they themselves are at risk of becoming ill and dying, and how we're going to link it to the problems in the community, how we manage infection and how we manage the fear and social isolation of patients in the community. So that's a kind of overview, and I think we're going to hear now about some of the more specific issues in the clinical management, including from Dr. Chitra.
Over to you, Dr. Chitra.
Thanks, Stephen, for this opportunity to raise this important issue in this webinar. And thanks, Gary, for leading the briefing note and introducing the topic today. So I'll be speaking more about the practical and the clinical perspectives in terms of how palliative care has a role in addressing psychological, social, spiritual distress in the context of COVID-19. And then how do we get, move forward doing it also? How do we really plan, especially in different settings across the world? Next slide. So as Gary had pointed out, there's a great deal of, there's a great deal of social instability, financial instability. There's a lack of access to care. There's a pause in community activities. There's forced solitude and loneliness coming about because of that. And then also, when you look at vulnerable populations like the palliative care patients that we take care of, there is a fear of death and dying. How will it be managed in the community? The symptom control, a sense of demoralized fear, and also specific populations like the displaced populations, migrants, single persons living alone with no care. So these are all aspects that we have to look at. So what is palliative? We all agree, and we are here today because we agree that palliative care is an urgent need to be integrated into this care for the pandemic. And I think palliative care is ideally placed because of the emphasis it gives on psychosocial management also. We always prioritize psychosocial care. So, but it is a challenge in settings like my country, India, where palliative care is not fully integrated. But still, along with providing care, I think there should be a focus on the strong advocacy of integrating palliative care. So we should form task forces, even if it is small and local, and prepare guidance notes. And the recommendation is that we plan and integrate psychosocial support along with the triage decisions, starting from the community where people with mild illness of COVID-19 are quarantined or isolated. So psychosocial support should start from there towards the end of life, death and dying, and then taking care of the family during bereavement. We should also try to ensure availability and the ways to provide medications which are needed for psychosocial distress, like antidepressants and anti-anxiety medication. People are isolated, people are living alone, like I said before. So strengthening the community networks is very important, where volunteers and people in the community can take a very good role to check in, to monitor, or even, provide relief measures, go and give medications which are needed. So the local systems should be actually involved. And we should also anticipate and plan for emergency care. There could be acute distress situations like a panic attack, or people with existing mental health problems having an acute psychosis. Or we know that the lockdown has brought about, substance use issues where alcohol is not provided. There's a great debate happening in our country, especially in Kerala, where alcohol consumption is very rampant, that whether we should give alcohol or not. So acute withdrawal state. So, all these come as part of this distress. So we should be prepared for this emergency care, and also to empower the team. Not only I think we should empower the non-palliative care healthcare workers to handle the patients and caregiver concerns, and also our own palliative care teams, because the whole situation has changed, and they should be enabled or encouraged to adapt to the new situation. Next slide, please. So then how do we offer support from the time of diagnosis? So as I said before, it should be a proactive approach, and then it also should have empowerment. The intervention should have an empowerment of other workers. And as we have been discussing in the previous webinars, communication is probably the most important factor. And with the challenges that this pandemic is bringing, using digital platforms, helplines offering support, using platforms like Zoom, we should try to communicate and maintain the connectedness. We should have strategies to dispel the myths about COVID-19. So we should go to that level also in educating people about COVID-19, and rely on our communication skills to offer empathetic communication. So we reassure them. We should focus on integrating psychosocial support into the goals of care discussions through the process, through the ethical framework. And in the triage team, palliative care experts should be taking a role as a supervisor, and to help the team take decisions when there is even the intensive care or anywhere, so that the process becomes smoother. And of course, like this webinar is about, is to make sense of the psychological, social, and spiritual distress that comes along with this journey. There are some specific issues that this pandemic brings, and we are witnessing, and one is stigma. Stigma is really, we are seeing it very much in India, like the patients, families, the healthcare workers who are in the community, or even, who are in the hospital, are discriminated because they're taking care of COVID-19 patients. So that's one area which should be given focus in terms of education, in terms of, reassurance, and mental health professionals should take a role in that. And palliative care professionals also should be, because they work in the community, take an active role. Like I said before, substance use is another area that will come, right on your face. And all this together, along with the fear and anxiety, and probably with existing issues in the family, putting, the family in a confined space. Domestic violence is also becoming, very visible. People are talking about, domestic violence, and helplines are being, set up to look at these issues. I think burnout is also important. It's not only for the healthcare workers, it's very important for the caregivers generally, the families who are, shifting roles, taking care of people in, in a very new kind of situation. So it's very important that we focus on these specific issues as well. Next slide. So this is just a slide to show how you make sense of the distress, because people with emotional distress, they respond with emotional responses, and we always see them as emotional responses, like saying that person is angry or sad or irritable. So this is like a journey where all of us being healthy, you can see the green side where we do have normal mood fluctuations. We are calm, we hope that we are calm, and then we cope well. We perform quite adequately, we function quite adequately, we sleep quite adequately. But then when the situation around us changes, the stimuli causes changes in our internal cognitions, our biological responses, and then we start reacting differently. So this normal mood fluctuations change into irritability. And if we cannot cope, if one cannot cope with these emotional responses and the internal changes that is happening, then they go on to this journey of being injured and then ill. So then it goes on to being angry, anxiety, pervasively being sad, and then goes into aggressiveness, excessive anxiety, panic attacks, depression. So this is like a journey. And so when you are in this end, you are normalizing and helping them cope. But then when they go to that extreme end, then they need specific care from specialists. Next slide, please. So then how do we manage distress with the challenges that COVID is bringing? Because psychosocial support relies on communication and the therapeutic interaction you develop and establish with people in front of you. So how do you maintain this emotional closeness, maintaining the distance? One of my colleagues had said that being human wearing a mask, and there was another person who said that how do we have a smile in our voice? when you are wearing a mask, how can you bring in a smile in your work? So there are several ways that people are thinking of how do we maintain the emotional closeness. And then also to educate people about the psychological process that is happening within in terms of the emotions and how to cope and normalize these reactions, to tell them that it's all right to be fearful, all right to be anxious, and facilitate coping. So you enhance their coping competence, you help them ventilate, and then you validate, you listen to them. There's a non-judgmental approach. You help manage crisis, looking into breaking the goals into very realistic ones in front of you, so that you say that let's look at this problem today, which is very easy to manage. Problem solving approach, where you manage a problem which is a priority, and you facilitate the family and the person to look at the problem. I think it's also a good step to use recovered patients and families to support each other. They have gone through the process and they can offer support to others. So these are some of the ways that you can help coping. There are some somatic symptoms that come with psychological distress, like aches and pains, sleep disturbance, headache, fatigue, extreme tiredness. So to reassure them, to address the anxiety which comes along with it, and tell them that it is part of the psychological process is very important. But it's also important that we focus on the physical symptoms that will exacerbate in people with chronic illness, like pain, people who are on opioids or analgesics. So we should be very careful. When the distress goes on to moderate or severe intensity, then we might have to go to the need of, along with psychoeducation, helping them cope. We'll have to use medications like selective serotonin reuptake inhibitors or benzodiazepines and benzodiazepines for anxiety and depression. So we can use this. Extreme anxiety, agitation has been dealt with earlier in terms of using parenteral benzodiazepines. Next slide. So this is an algorithm we developed in Kerala as a resource for people to follow when they are managing people with distress. This was part of an e-resource toolkit that we developed as for palliative care recommendations for the state government. And the Indian Association of Palliative Care is also bringing a set of recommendations. So this actually shows how you communicate, you use your listening skills, and then you elicit the symptoms. And we have also recommended the use of a simple tool like distress thermometer. You can see it beneath, and when you score below 4, like I said, your strategies of educating the person, addressing stress and strengthening the coping, and promoting daily routines in terms of sleep hygiene, simple measures that you can help them in coping. But when the distress goes above, then you have to use medications. And on the right end, in the red column, you can see that when there's no improvement, and there are some red flag signs like agitation, confusion, when there is some psychotic features like delusions or hallucinations, and most importantly, suicidal ideations. We have witnessed, some suicides people have ended their lives. Both, we have seen family members, people who are quarantined, and even healthcare workers who have taken their lives. It's very important that we identify and then we offer care or, refer them to specialist care. Next slide. So I'm just ending. This is my last.
Oh, sorry.
That's okay. So this is my last slide, and this is the, I think, very important, very, very significant that you bring in meaning and purpose in this, situation of great uncertainty. How do you bring it and give spiritual care to people? So you help them, you facilitate the process, and find the strategies people use to connect inwards, reflect within into their own beliefs and values, connect outwards to others, to nature, to the relationships outside in the community, and of course connecting upwards to God, using faith to the universe. And so when you bring in meaning and purpose, you really make a difference in their lives. I thank other contributors to the briefing note as well, and that's the end of my presentation. Thank you.
Thank you very much, Gary and Chitra. I've often felt, Gary, that death anxiety is actually one of the biggest obstacles for palliative care in general, that so many people just don't want to deal with the reality of serious illness and dying. And Chitra, Kerala is the model for, I think, community network support globally. I think lots of us look to the neighborhood network and some of the other creative work done in
Yeah.
Carla to, so hopefully that will be one of the things that helps
Yes.
India cope, or at least Kerala cope with
Yes.
COVID-19. So we're going to press on to the next presentation on grief and bereavement for family members who can't visit sick relatives or attend funeral services. This has been, I think, a really key topic in terms of particularly the value add that palliative care brings to the response to COVID, because we're, able to, this is just such an issue in terms of grief and bereavement. And we're pleased to have with us today Jenny Hunt, who's a palliative care social worker and bereavement therapist living in Harare, Zimbabwe, who's going to be presenting on this topic. This is the briefing note, by the way, which you can access, as I said, through the globalpalliativecare.org website, and the names of the contributors to the development of this briefing note, two of whom, in addition to the presenters, or in addition to Jenny, are with us today, Dale Larson and Patty Annawalt. So over to you, Jenny Hunt.
Great. Well, lovely to be here. So just following on from what Gary and Chitra have been able to talk about, I think it's a really helpful concept to talk about the grief and bereavement of people who are mourning the death of a loved one who is actually infected by COVID-19, and those who are affected. This is a concept, of course, from the HIV/AIDS epidemic as well. But I won't go into too much detail in the first one because I think Gary and Chitra have covered a great deal of that. But obviously the factors then impacting on the bereavement, because there's been the physical and social isolation before the onset of symptoms, during the illness, and during the hospitalization, and of course during the dying process. So they've discussed that a little bit. But just to put a little bit more onto it, is that the lack of being able to care for your loved one really does affect how your grief process may develop. And there may have been limited, if any, communication possible. We'll talk a little bit about that later, about the difference that can make with hospital staff standing in as sort of proxy. Then, of course, the lack or the delayed information to the family members when the patient is deteriorating and then dying. And of course, anxiety, again, we've talked a little bit about that and really highlighting how anxiety can be increased with that. And not to forget the guilt and possible remorse at the possible infection route. We know that a lot of the health workers are living with this concern that they just may have been the ones to infect their loved ones and other members of the family. If people have been socializing or going out, there may just have been a risk of infecting that patient. So that's with regards to someone who's died from COVID-19. But another aspect of those who are affected by this epidemic, not actually infected by this virus. And that, of course, means that people are not presenting for their usual tests any kind of niggles and aches, possibly holding back, not wanting to go to hospitals and doctors' rooms. So delayed presentation. And of course, the resources are diverted. I think we've all had experiences where the health workers are not available, or a surgery hasn't been able to open because the health workers are diverted to the hospital, equipment as well, and medicines. And of course, the emergency responses are slowed because of these temperature checks, the sanitizing and the distancing that needs to go on. And just to give you a little bit of a case example, I'm working with a family at the moment where on Easter Monday, the husband, father, had tightness across the chest, difficulty in breathing. His wife took him to one of the health centers that had been advertising really fully about how well prepared they were to deal with the sanitizing and the infection levels during this epidemic. So it was, pretty well advertised. Took him there, but because of all those checks, he was left in the car while his wife had to go through temperature checks, sanitizing, before she could even see anyone. Then that reverse process having to happen, by the time he was checked out there, told to go to a next door facility for further checks and an ECG. Again, the same thing, all locked up, the security guard, unwilling to let anyone in until it was ratified by someone more senior. So these delays meant that eventually this man collapsed on the pavement, died a couple of hours later, and his family will now never know whether those delays would have made a difference to his living or dying. No one will know, but that is what they will now have to live with. Next slide. So when we're talking about grief and bereavement, rituals are really important. In the usual course of events, rituals such as funerals, memorials, and social gatherings are really important in terms of starting off the grief process. And with this kind of situation, we're having to look at those again and really reviewing the purpose of these cultural rites. And these, of course, vary between and within cultures and families and societies, and they're dynamic and they're evolving. And that's terribly important to remember. It's worth remembering that they are dynamic and evolving, and they will be doing that during this time as well. So this is nothing that new in terms of how we understand rituals and the death process and the grieving process. So these cultural rituals, firstly, of course, dispose of the deceased person's body, and that's a really important part. But they also help the family face the reality of the death. It's an opportunity to offer and receive support from others. And Gary mentioned again the importance of that kind of support from society. And they also mark the significance of the deceased within the community. So these rituals are really important when we're looking at the individual within a community. But of course, these are now on hold or changed or cancelled. And we find that families are on this liminal state, this sort of no man's land, until plans are finalized or alternative options are found. So because these rituals are dynamic and evolving, already we're seeing extraordinarily creative ways to deal with this dreadful situation. There are online gatherings, candle lighting. This family that I'm working with at 11 o'clock on the Wednesday had informed all of their loved ones all around the world and said that this is the time that we will be remembering him and to light a candle. And that was incredibly powerful for this family. So eulogies online, pictorial images, all of these can be done online and through the internet. And that's a huge plus. Recorded events, if there is a funeral, perhaps with 4 or 5 people, depending on which country you're in, you're allowed so many people. Being able to record that and share that online. And we see a lot of notices happening that the funeral or the memorial service will be undertaken at a later date. I think one of these issues about the mass graves that we saw happening in New York a short while ago will require specific attention. And I think any family who have had to bear that will really have some specific issues that require expert care. And again, the previous talkers mentioned the absence of this compassionate physical touch and comfort. It is a very human need to reach out and hug and touch someone who's in emotional pain and to be able to comfort. And we aren't able to do that at the moment. And that is a really difficult thing, not only for the bereaved, but for the people trying to console. It's equally frustrating, well, not equally perhaps, but it's certainly frustrating for people wanting to share and console and not being able to do that. Next slide. So just a word of caution, because we're learning and hearing a great deal about traumatic grief and the trauma that's surrounding this entire epidemic. And I certainly don't underestimate that, and I think it's very valid, and there certainly will be people and families where they will be experiencing traumatic grief reactions. But in general, because of the fact that we are able as human beings to adapt and manage situations with our capacity to really explore different alternatives, I think what we are more likely to see and what we should anticipate are more complicated reactions in the grief and the bereavement process. But generally, and I think possibly what we will see is a greater demand on bereavement services, a greater demand on skilled counseling with this. But I think enabling people to grieve healthily is certainly going to be possible. And already we are seeing this with just the fact that families are able to develop ways of managing in this kind of very unprecedented situation. I also anticipate much more anger. We all know that in the grief process, people generally feel a great deal of anger at the deceased, at God, at whatever it might be. But I think with this situation, we are going to see much more of this, possibly at specific health institutions, my clients in particular, I'm thinking of. Policymakers, the ones who decide who you can see, how many people you can have at a funeral, how people can behave during this epidemic. And of course, the global response, which is that times so much. So I think there's going to be much more of that. And being able to deal with people's anger is a part of working with bereavement. But we have to be more alert to that and more accommodating of that, I think. I think because of this liminal state that we're seeing with people who can't finalize perhaps the funerals and can't finalize being part of a community or a family to be able to grieve together, this feeling of not quite real is again what we would see in the early weeks, months of any kind of grief reaction, where people are disbelieving, can't quite believe that this has happened, but this is again going to be enhanced, I think. Of course, the frustration at delays in paperwork, registering the deaths, being able to finalize things. We all know with people who are grieving that that is part of the very unpleasant chores that have to happen within the first few weeks and months. And when this is all delayed, that's just expanded. Separated family members. You know, we're all in a global community anyway, and at the time of lockdowns, we know of many, many situations where family members are stuck in different countries, couldn't get home for the death, still can't get home. So grieving alone, doing the best they can online, but actually grieving alone, and perhaps in environments where their friends, the people who are near them, maybe their work colleagues, never knew that family member. And that makes quite a difference to the grieving process, where you're having to grieve with strangers, really, who never knew the person who you're grieving. So the social networks that we would always draw on, that Gary mentioned, cannot operate as usual, and it all has to be done really online. And I think that kind of physical distancing, not being able to reach out and physically help people, the way in which people are having to deal with this on Zoom, on Skype, on calls, it has to be good enough. And I think that's a term as well that we recognize from many years of being in counseling fields, doing bereavement work, where things aren't perfect, but they can be good enough. And I think that's what we have to encourage people to work towards. Of course, there's always the possibility of other family members being infected, the possibility of another death, either from COVID or from delayed care to an existing condition, and therefore the fear of further deaths. And explaining the situation to children is important. When we're doing bereavement work, we're working with families. So it's terribly important to include the children in these conversations, provide honest information, provide the reassurance, and also ensure that there's a safe place for them to express their emotions. So children always need to be included in this kind of situation. Next slide. So just a few suggestions to end off with. And again, encouraging the health workers and the systems during that dying process, if possible, to enable the contact. And then just after that, it's about assisting families and the funeral agencies regarding the disposal of the deceased in the best way. And this again may be compromised. It may be delayed. It may be on hold for quite a while, but it needs to be done sensitively and with compassion. So where possible, we need to work and facilitate families and funeral agencies to do that. And never has it been more important, I don't think, to really highlight the principles of how we work with bereavement, which is always this compassionate listening. It's always having the ear, no matter what the experiences are, no matter what the emotions are. I think more so now, this curious inquiry, none of us really knows what this situation means to people. So being curious, genuinely so, and inquiring, what is that like for you? What does that mean to you? I think is even more important than ever. A safe place for expression of emotions. We've talked about anger. I think there's going to be an enormous need to just allow that in a safe place. Exploring these alternative strategies and resources, being creative, never more so than with this kind of situation. Providing information, not only just about the bereavement process, what to expect, but the kind of complications that they may have as a result of the hiccups that go along with this, and about what resources are possible. So providing that kind of information can be very helpful. I think what may really be helpful in months to come will be facilitating review of the death with appropriate personnel when the time allows. We know with other bereavement work that sometimes allowing that family or facilitating that family to talk maybe with the doctor or a nurse or the cleaner, the last person really who saw their loved one, can be extremely healing. And facilitating that, I think, is going to probably be increased. And just a final word on recognizing the uniqueness of every single bereavement. We pay lip service to this, and hopefully we do this all the time, but never before has it been so obvious to me that the numbers that we are faced with all the time of the infections and the deaths around the world, it becomes anonymous globally. And I don't think that we can afford to make that mistake with our bereavement. So we really need to highlight the uniqueness of every single bereaved family that we are working with. Thank you.
Thank you very much, Jenny. Excellent presentation. I want to remind our listeners that we would like to encourage you to submit your questions to the chat box and to send them to everyone. I think it is important, Jenny, that we both help the people that are having the most difficult time with this in terms of grief and bereavement, but also understanding that most of these, that most reactions in bereavement are not pathological or wrong. It's just that, we've got some rather unusual circumstances that make bereavement more complicated than it would ordinarily be. And this idea of liminal state, I like this idea. Just being in kind of a limbo. And there are many parallels, I think, to other situations, humanitarian emergencies, terrorism, where you have the similar inability to have closure. And hopefully Joan Marsden, who's with us, will have a comment or two about that. I also, since we have a little bit of time, we have, as I mentioned, Patty Annawalt and Dale Larson, who are members of this task force, who are on the call, on the webinar. If they want to make any comments briefly, you're welcome to do so before we go to the next speaker. Or not.
There was one comment in the chat about how do you support people that don't have the online option, which was a great question, because that can be more challenging, I think. Hopefully they have telephones, or even with the social distancing, hopefully reaching out. I think sometimes people tend to hold off and not reach out. And so we want to encourage the bereaved to reach out as well and let other people know what they need for support. So oftentimes people care, but they don't know how to provide support, so they don't say anything. So I think encouraging the bereaved to reach out and access the supports that they have, whether it's across the way because they can't be close, but any way we can be creative in that regard is important to encourage people.
Thank you, Patty. That's good counsel. Any other comments from the panel? All right. We will move on then to the next presenter, who is Diane Gray, who is the Chief Innovation and Patient Advocacy Officer for Acclivity Health. Along with me, she's a member of the Board of Trustees of the Elizabeth Kubler-Ross Foundation and is CEO of a healthcare communications company. Diane is an exceptional person and quite an expert on communication, as well as having had lived experience as a hospice and palliative care caregiver. So Diane, over to you for your comments and reflections.
Good morning. Thank you so much for inviting me to be a part of your webinar. You know, I've really enjoyed the presentations thus far, and it's been quite informative. And I've been sitting here kind of collating all of this information. You know, the unique situation that we find ourselves in is that we are not necessarily, we're coping with this in silos within our homes, but we're also coping with this as a global community. So all of the barriers and all of our vulnerabilities are exposed. Death knows no boundaries, as we know. And I want to thank each of the presenters for your reflections. You know, Gary, I heard you talk about the unique stressors that were occurring in this time of this pandemic globally, that this is a time of emergency palliative care, that in the past we had the situation of, you know, the diagnosis, and many of us know that with palliative care, it's available at the time of diagnosis. However, a lot of patients come sliding into home plate, you know, with palliative care to the rescue. Now that trajectory has sped forward rapidly, and that people are not equally infected. We're having this concept of health equity right at the forefront. People are not receiving the care that they need, and they're certainly not receiving the grief care that they need cross-culturally. And that's very concerning, and there's an unprecedented coordination, but there's also an unprecedented lack of coordination. Advanced care planning is poor, and there's poor symptoms control. To that, Chitra, I'd like to reflect upon what you said too about things that we all have within our capacity. It's just whether or not we employ them. Empathy, compassion, and reflective listening are more important than ever. And that goes to what the attendee asked in terms of what can we provide without online resources. We can still provide compassion. We can still provide empathy. We can still employ reflective listening, but I'd also like to add in active listening, which is in short supply when we have a pandemic, traumatized individuals, and people coping as they know how. Sometimes the best thing that we can do is to actively listen, which is difficult, right? Because we have our own stressors. Jenny, I found your presentation compelling because you spoke too about guilt and remorse, about possible infection and infecting others in the community. But you also brought up, and my question is about grief rituals and anger being front and center for many, many individuals. And I do agree with you. I think we will see that rise as we see the length of time for people becoming more and more confined. We're seeing that here in the States, certainly, with the entire state going to their court system to overturn the ritual, the governor's ruling, rather, to stay in place. I think that's a global issue. You know, to that, I'd like to offer up these reflections, and I'm also reading the questions here on the side. I think we need to consider where our own rituals for healing and for mourning are needing to expand. We need to rely more and more cross generations. And I'd like to offer up that as a question within community. Who is our community? Typically, we look within our circle, right? These are our generations that we're comfortable with. but I think there are opportunities for growth, post-traumatic growth even, if in this situation, to reflect back on Chitra, which you were talking about, meaningfulness and purpose. We know that that's critically important, and we can find that in looking to our younger population to educate many about, technology. I know that people feel that they have a lack of resources. That's true, but I think too, our younger population will also be able to help us find new and meaningful ways to connect using our younger generation as our teachers. And that will also engage them and help them to find meaning and hope and purpose in a time where they're feeling a lack of connectedness themselves, which leads to a whole host of other problems that none of us want to see down the line. But also too, I think it's a powerful time to reach out and to connect to our elders in our population. They're feeling an incredible sense of desperation and isolation. And those elders can help to teach us about wisdom and ritual. And those rituals are incredibly important right now to help us to build those bridges between the young and the old, the elders teaching rituals and wisdom, and the younger population to also help us with the technology to memorialize this time can help to build meaning and significance, to Chitra's point. Also too, I think I'd like to ask us to encourage new communities and new connections. These don't have to be permanent connections. I think it's an important time to look at how we can communicate with new people. Sometimes I've found that in times of desperation, we think that things should be as they are, but they don't have to be always. So in creating new connections, we can say, look, who is here now to help us through the now, through the short term? Whether those people are here forever, who knows? I know in my own work with the bereaved and the people who are absolutely mourning, they feel a sense of anger, to your point, Jenny, that the people that they depended upon are not dependable. But that's okay. They don't have to be dependable now. They're coping with their own things. So who is here now? And we can encourage this new sense of community. And back to the good enough, right? What's good enough for now? To go back to Chitra, your talk about, meaningfulness. I think if we can figure out the why, it will, to Viktor Frankl's work, it will help us navigate the how. Meaningfulness and purpose is really difficult in this time of COVID-19. Why is this happening? I don't know, but I do think that we can help people find the why within their own communities if this whole global community of care can help to navigate this unique time. Explaining this to children, I think we can explain some things to children, but I also think that children can explain a lot to us. I think children are significant and relevant teachers in this time, and it can help us to encourage playfulness and levity and laughter and light, even though these are desperate, meaningful times. I think to encourage, to Elizabeth Kubler-Ross's work about cross-generational teaching and learning, this is a powerful time for that. And I think we can use, Jenny, to your point, curious inquiry, brilliant, curious inquiry to children, curious inquiry to our elders and to our colleagues as well. Unfortunately, I've seen a number of casualties that have to do with mental health issues. And I'd like to ask all of us to employ curious inquiry to our colleagues as well, as though we are caring for. How are you? What's new? How are you managing? What are you doing for self-care during this time? Because although we know many of our constituents and our colleagues, our patients and our families are dying thanks to COVID, we're also seeing some real mental health, mental wellness, I call them, issues that have to do with self-harm. So I think, Jenny, to your point, curious inquiry is really, really important during this time. And I think in reflection to close my part here, I think that if we can help ourselves through curious inquiry, helping ourselves to take time for meaningfulness and reflection and meditation or prayer, whatever your method is, I think will help to also increase care for our communities. I'm very concerned about the mental health and well-being of the practitioners globally, and I think it's a good time to dedicate some conversation to that as well, Stephen, going forward. Some real closed group type of conversation about self-harm, but also self-care. So I just want to thank you all for being here. And if I can contribute or be a resource for whomever, I'm happy to help. Thank you.
Thank you very much, Diane. I will mention that we are doing, one of our webinars will be on self-care in the coming weeks in June. So look forward to that, along with a session on spirituality and palliative care in this environment that we're in now. Anyway, thank you, Diane, for those wise comments. We now have about a half hour left, so it's time for questions and answers. And I've seen quite a few new questions come in, so thank you to attendees for putting forward your questions and thoughts. And I'm going to, before I go to Kate for the questions, any other final comments from panelists? Unmute yourself if you want to say something.
Yeah. Hi, Stephen. It's Joan.
Good.
Just maybe to mention the humanitarian situations. And of course, there are so many different types of humanitarian situations. But part of the life experience of anyone in that situation is loss, grief, and bereavement. They leave behind their homes, their families, their sense of identity, the meaning that's linked to their social and their professional roles, and their roots and their family history. And so it's really a difficult situation because we know that PTSD is higher in these populations. And we also know that over this period of COVID-19, many of the NGO groups have actually been excluded from places like refugee camps. So all of that I've listened to today from the three excellent presenters and Diane, your wonderful summing up, is relevant to the humanitarian situations. And the work of Denai Papadatu and her team in Greece, I think is really worth looking at.
Thank you very much, Joan. Yeah, I think I couldn't agree more. Any other comments from panelists? Okay, great. All right, well, thanks again. We're going to go now to Kate Franklin for questions. Kate, are you there?
Yeah, thank you, Stephen. And just to say thank you again to all the panelists and also to Diane for that very powerful reflection that you gave us. So the first question is for Dr. Royden. You discussed the realities of poor quality of dying and death due to COVID-19. How can mental health workers support family members who have experienced this reality?
Gary, make sure you're unmuted.
I'm sorry. Yes, thank you for the question. I think it relates to many things we've been hearing about as well from the other panelists, and also this question of bereavement morbidity, because there is a link between poor quality of undying death and more bereavement morbidity and more complicated. And I think our best interventions in terms of that have been proactive interventions. So I think we need to think in a proactive way about how to engage families in conversations, how to provide support to families. And we've had most success in providing bereavement support to families that we've been involved in during the course of the illness, much more so than when we haven't been involved beforehand. So I think it involves support, it involves meaningful conversations. And sometimes meaning, and Chitra talked about this in a very good way, but sometimes meaning is thought of in some very high-minded way. You know, people think about existential things, but really meaning is just helping people make sense of their experience. That's what spiritual care is. It's about open-ended conversations, allowing people to talk about their experience, their fears, and their concerns, and to feel they have support in that. I think that's some of the most powerful interventions, as well as all the other things we do in palliative care, you know, symptom control and location of death. This is particularly important in ICU settings, I think, we know the incidence of PTSD in family members and in patients is very high in deaths in ICU settings. And I think we have to pay a lot much more attention about how to provide support. And we need to think, as some of the questions are getting at, of innovative ways. Our usual ways of providing support may not be possible. We need to think about a lot of innovative ways that we can do that.
Thanks so much. And we have a follow-up to that question, which is we're also examining how the social isolation has affected the quality of death and dying. Can you speak more to that?
Well, it's interesting. I mean, social connection, human connection, social support is one of the things that most affects death anxiety, fear, and the quality of dying and death. So those two things are clearly demonstrated. We don't yet have data. It's too soon to have data about how this is all played out in COVID, but we can guess that's what's happened. So we need to think about how to provide that. You know, much of psychology and psychiatry, for that matter, is focused on individuals. We think about death anxiety as an individual state, but actually it's a socially determined state. How much death anxiety someone has is very much determined by the support in their context. And I think a number of the panelists have said that, especially in the context of isolation from families, the support provided by healthcare providers becomes that much even more important. They may be the most important human connection some people have near the end of life. One final thing sorry.
Sorry, I was just going to say, can I just add a little something on that? Because I think what we also can do is use techniques that we would often do with bereavement, which is, if you could have said something, what would you have said? Or, you know, writing these things down, using imagination, using fantasy after the event. Because so often with grief, people have got, you know, the if onlys, what if I had done this differently, whatever. And in this kind of situation, we're going to be dealing with that a great deal. So there are these techniques that we can use. And again, it's not ideal, but they are there.
Gary, did you have more?
I was just going to say that there's another question that came along about measures. People are asking about their measures that we can get at in patients and families, and there are a lot of existing measures. They aren't specific for COVID, but it's really the states that COVID produces. There's measures of traumatic stress, there's measures of death anxiety, there's measures of attachment security, of depression, of social support, of caregiver burden. So there's a lot of existing measures for people who want to assess these things clinically or to study them from a research point of view.
To that question, Gary, Stephen, I'm just answering that about the measures for distress. I also noticed that. So there's a lot of questions, especially with research happening in COVID-19 context these days, about what tools or measures can be used for research as well as clinically. So as Gary said, there are a lot of, if you look into some studies that have come from China, and a lot of tools, existing tools have been used. One is also the impact of event scale, which has been used. So, but I feel that a simple tool is enough, like a distress thermometer, where you have to the tool always helps you to just, you know, identify and explore further. So I think the qualitative component is very important to The main focus should be how we explore and find further issues beneath, and the tool should not be used just as a checklist.
Great. Yeah. Kate?
Thank you very much. The next question is for the whole panel. Has anyone had the experience of patients on ventilators having their sedation lessened so as to allow them to say goodbye to their loved ones?
Well, there have been some efforts to try to communicate with people who are either ventilated or getting oxygen therapy using telemedicine, iPads, and being able to communicate, because particularly I think the problem in the ICUs is that there are so few visitors allowed that they, persons unable to have those by the bedside. There is an effort to try to come up with some guidelines in the UK for allowing family members to be with the person when they're actively dying with proper protective equipment. But it's been I think a major problem with people on vents, because particularly if they're heavily medicated, they're not able to actually communicate. Any other thoughts from the panel?
Even I do. I just wanted to comment, one of the frustrations hospice staff are having is the nursing facilities are keeping everybody at bay and not wanting visiting, even from hospice staff. And yet they'll say, you can assess when you're within an hour of death, they'll allow the family in. And yet the hospice staff don't have a crystal ball to know when that is. So it's been a real source of frustration for the hospice staff and the families.
Thanks, Patty. Kate?
Thank you. In high incidence settings, many healthcare workers are providing palliative care and they are overwhelmed by the amount of death that they're seeing at the moment. How can we address health worker trauma or secondary grief now and also in the future as the overwhelming death and dying decreases?
I could speak again to that. At the National Hospice and Palliative Care Organization, we've had this conversation recently, and a colleague of mine from apart, because everybody there in the particular hospice out on Long Island was very impacted by hundreds of deaths. So she, from another part of the country, through a Zoom meeting, provided grief support virtually. And we're starting to get calls as well in our community in Pennsylvania to provide that type of support. So as bereavement staff, we are through Zoom making those options available for healthcare workers that are really struggling.
Thank you. The next question is around resources, and which quick guidance and resources are available to support health workers who have little or no training in basic palliative care and who find themselves suddenly needing to provide palliative care to patients at treatment centers? And also, is there a network they could turn to for mental health support if there are no national resources?
I mean, on the mental health resources, there's a wide range of online mental health resources available. Stephen, I wonder if maybe there's some way of making that available to the participants after the...
Yeah, both IHPC and WHPCA have dedicated resource sections on our website. So I would have you suggest you go there. If you go to ours, the COVID-19, you'll see a section for professionals, which will have links to communications training as well as support for healthcare workers. And I think IHPC does as well.
I just want to say that we have developed an e-resource toolkit on Pallium India's website. I'm sharing that link on the chat box. Moira was also asking to say details about. We started off with the recommendations, and now we have started online training through the ECHO platform for healthcare professionals who are not, who don't who do not have palliative care training. And we are also recording short webinars which we'll upload so that people can access and then learn how to manage persons with infection or their families. And the psychosocial part is a significant component of this e-resource book.
We're also nearing completion of a briefing note on self-care, which is part of this issue. Dale Larson's on the panel with us, who's been leading on that effort. Dale, do you have any comment? Unmute yourself.
Yeah, I'm trying to. I can't start my video, but that's okay.
Go ahead.
There we go. Yeah, well, I think that it's going to be an enormous challenge. I was trying to start my video there. There we go. Start my video. The challenge of supporting the healthcare workers is going to be enormous. I think that's what we were addressing, Chitra. Was it? Or you know, one of the findings in the studies of end-of-life professionals revealed that the number 2 stressor was work overload, which of course everyone's experiencing with COVID in the front lines. But the second most major stressor was no time to grieve. And for sure, the people doing this work right now have not had time to grieve, and we're going to have to address their experiences of grief and loss doing this work and at this time. So we're going to have an enormous challenge ahead of us. Also, I'll go back to Gary's point about social determinants. I think that there's a lot of disenfranchisement that's going to happen because it's going to be hard for families to talk about a loss like this for a lot of reasons. One is that, unfortunately, not kind of reminiscent of the AIDS epidemic, people are going to feel a little less open about a loss to COVID because, unbelievable as it is, people will sometimes fear them. And oh, you were with your loved one and they had this disease, and you know there's going to be a lot of social constraints that can happen in follow-up with healthcare workers and with the bereaved as well.
Fear of contagion, Patty.
There's for physicians, there is a physician support line in the United States, and it's staffed 24/7 by volunteer psychiatrists. So that's another option. You want me to read the number or put it in the chat?
Yeah, we have a very global audience, so I'm not sure if it's available.
Okay.
People outside the country.
I think this issue of staff stress is a very important one. I think there has been a fair amount of attention to it, and I agree very much with what Dale has said. And certainly at our center and our cancer center and some other places, they've established an organized program of support for healthcare workers who are on the front line dealing with COVID patients or in the ICU in a proactive way. It's a model of peer support, and it's also a model of mentorship, but I think we also need to think of it in a proactive way. We shouldn't only be thinking about, I think the panelists would probably agree, it's not only about sometime later, how do we manage the grief, it's really in real time, how do we help people manage. And one of the ways people manage it is by having an opportunity to process it, to talk about it, to feel support, to feel not alone in it. The most distressed people, I think, are the people who feel in the middle of this and that they're all alone in the problem.
Your comment about proactive versus reactive.
Yes,
yeah,
yes.
Very true. Great. Good discussion. Thank you. Pete, want to bring us to a new topic?
Sure. We've actually had quite a few more questions come in on the topic of care for healthcare workers. So if I could just go through 3 of them and then ask the panel to respond. The first one is, in spite of years of training and practice, talking about death and bereavement counseling can have a significant impact on the counselor or the psychologist. Could we please discuss certain ways through which bereavement counselors can take care of themselves emotionally through this? And then the other one is for healthcare professionals who are grieving the number of patients who have died without adequate care, how can we work with them? And what advice would you give to hospital managers to better support their staff at this time? Thank you.
I could say one or two things about
And
that. Or someone else did. Jenny, did you want to say?
no, carry on.
You know, people talk, we talk a lot about the distress that comes from talking about death and dying, but actually I think there's more distress that comes from not talking about death and dying. And I think that is the biggest cause of burnout, actually, is that people are filled with these overwhelming feelings that they have no plans to talk about it. And so I think this goes back to some of our basic training. One of the points I've made before is that I think in palliative care, there's actually more attention in training to managing physical symptoms than to how do we manage emotions, talk to patients about emotion-laden things. So I think we need to think about our training of all of our disciplines and how do we have these difficult conversations um, so that we provide opportunities for patients to process them and opportunities for ourselves to process them with patients and with staff. I think that's one of the ways in which we prevent that kind of morbidity in staff. The second point you raised, I think, is related to moral distress and around inadequate care. And that's a whole topic in itself, but I think we do need to provide structures in the hospital where these decisions are made so that they don't fall back onto the individual provider who's having to make a decision or feels as if they're having to make a decision about whether an acute resource will be available. But how do we prevent and treat moral distress, I think, is a very important issue.
You know, to that point, if I can interject just briefly, you know, one of the things also too that I'm seeing is a significant amount of shame and guilt from providers feeling that they could have and they should have, but they didn't or they couldn't, because there's a selective process of who will live and who will not. And so unfortunately, the concept of offering up self-care or opportunities for discussion within the hospital environment or within the healthcare environment isn't sufficient for many providers because they're fearful for their jobs. They're fearful for the, you know, the shame that will come from that. So I'd like to also offer up one of the things that I've recently run across are private Facebook groups. Is it ideal? No, it is not. But at least there's an opportunity for anonymity in that through these private groups where individuals feel that they can just reveal all and say, here's what's going on within my environment, or here's what I did today. And there's a real sharing of information within these groups that is closed. And there are settings that are involved so that there's not a copy and pasting of information. And it is an anonymous type of environment. And at least that way, there's the ability to unburden oneself, at least temporarily. Is it a perfect situation? Absolutely not. But is it a temporary stopgap so that until the permanent groups and workplace healing can take place is set up? Yes, at least it's a temporary stopgap. So I'd like to offer that up. And because social media is now really buckling down on their settings and their privacy settings and they are global, that there is this global environment that is available.
I'd like to add, if I could, just that I think this theme of providing an opportunity for safe disclosure to a trusted other, a confidant, for both providers and for patients and families, mainly families who are survivors, is going to be, well, and patients, you know, those end-of-life conversations. I think Gary's point about, you know, being proactive and whether we have Schwartz rounds, you know, to the max and have those conversations as we go along about what this means to us, and the moral distress issues are enormous when you're triaging. If you have to triage ventilators, that's about its most excruciating thing you could possibly experience. And I think we really need to look at all the ways that this is a unique situation that's creating unique stressors for healthcare providers and for patients and families. It's remarkable. You couldn't have designed a more difficult kind of care context, I think, to overcome.
Thank you, Dale. I'm going to allow one of our attendees to ask a question. Stanley McCadden, are you out there? Hold on a second. You're unmuted. Stanley?
Thank you, Dr. Stephen, and all the speakers for a very useful session. And I think it's very timely considering our situation in India, because there is very poor or hardly any integration of palliative care with people who are dying in hospitals or even dying at home. So what we'll be left with is people who are bereaved. And so this is a very useful session, and I think all palliative care physicians or setups in India should become experts in this area, because this usually has been a kind of neglected area, you know. It's not been a priority for many. So thank you, and
Yeah,
I hope this will improve.
comment.
And also I hope there will be more integration in the acute dying situation also. Thank you.
Yeah, I think the healthcare profession, our colleagues in the healthcare professions and other specializations are, I think, coming to view the contribution that palliative care makes, particularly in this setting. But I think it can generalize to palliative care's importance throughout the healthcare system. Kate?
Stephen,
Stephen, can I say something?
Oh, yeah, please. Before you go ahead. Yeah. Jenny.
Okay, I just want to go back to the point about support, really. I think it's about time we really took it seriously about supervision and a safe place to be able to have care workers, whether it's from the community care workers, the home-based care workers, all the way through to specialist staff in hospitals. There's generally always a supervision element, which is very seldom taken properly. Usually just a senior member of staff is expected to do it. And from my experience, all the way from home-based carers all the way up to hospital staff, it very seldom is done correctly. And I do think that this is time now that we take this seriously and we get really good supervision where staff can offload without fear of retribution or judgment or failure, and be able to really use those in either in group sessions or individually, because I think this epidemic is really showing us the value of that. So I think it's time to revisit that whole concept as well.
Thank you, Jenny. Kate?
Thank you. The next question is about the stigma related to COVID-19. How can healthcare providers address community stigma and discrimination due to COVID-19 infection?
In India, what's happening is that mental health professionals, especially the NHANS, National Institute of Mental Health and Neuroscience, in Bangalore, has brought over a lot of videos on educating public in several languages, and it is broadcast on all social media and otherwise. And also, I think palliative care professionals and the community-based palliative care teams have a great role in reassuring and bringing out clarity in terms of the fear that people have regarding the illness. It's mainly the stigma comes out of the fear. So we have a big role in bringing down this attitude towards people who are involved with COVID-19, whether it be patients, families, or healthcare workers. So there is an effort going on, and there is, I think WHO has a page on that. So there are a lot of online resources also on how to handle stigma.
Any other comments from panelists?
Well, I just would like to say I think this is a huge issue. It's going to be a major contributor to burnout and to the longevity of people in their careers. That we have to find a way to. I love the idea, Chitra's, education in the community is absolutely going to be key, and. I'm thinking back again to the AIDS epidemic where Steve was very there in the early days when I was, and others too, I'm sure. It really takes a lot of attention to that so that we don't have the caregivers becoming isolated, and then they end up in the echo chamber. I want to go back to just the idea of sharing with confidants. And it's really ideal when those are colleagues who have that kind of instant empathy and can understand what we're going through, because it's going to be hard to find a way to communicate all this to some of our traditional sources of social support, although that's very important. But we need to be able to get professionals communicating with others who really understand in all these different ways. And I love the idea of better, more in-place supervision. That is just absolutely a great idea, and something Jenny's idea is terrific. Yeah.
Yeah, unfortunately, we've seen some suicides among health professionals who have been overwhelmed with stress. We see that in healthcare. I think it's a bigger risk nowadays given this environment. Kate, we probably have time for one more question.
Thanks very much. A participant has commented that the slide "Bringing in Meaning" by Dr. Chitra was brilliant. Could the panelists elaborate on this? How can we help patients to find meaning in the midst of their suffering?
I think we have discussed, everyone has wrote about this, the importance of meaning and how I think it's mainly like several of us have mentioned that we explore individually that how a person is processing this whole experience, what is the meaning of it to them, and how do they perceive life and the situation around them in terms of meaning, purpose. And I mean, I think it's happening to all of us when we are on our own. There's a sense of reflection. We are looking at what are our goals, what is the meaning of what we do, why are we doing this. So it attributes to each one in the role they are and in what they do in their life, and the support system which is missing now, like people go to temples, mosques, church, faith systems, which is not available right now. That is also available only online. So how do you connect with people? How do you maintain your relationship so that you can, have a coherent, a cohesive meaning of yourself, even in solitude? So that's what I meant. So how do we facilitate that process? I think we should also look into that in terms of exploring individually with each person that we meet with distress to know what suffering means to them and what distress in terms of connection in any direction, inwards, outwards, or upwards.
I would agree with what Chitra said, and there are many sources of meaning that people may find, but certainly healthcare providers can do a lot in the conversations they have to help people make sense of their own experience, to deal with feelings of shame and guilt and trauma and grief. I do think that we haven't treated the skill in having those conversations as something that is deserving of training and support nearly enough. I think we've done much more about that in the treatment of physical symptoms. We have much more clearly defined guidelines and training programs for how do you treat pain than we have for this. And I agree with Jenny. I think we need to think about what kind of initial training and what kind of ongoing supervision we're providing. We and other people are actually providing some of this internationally online, and I'd be glad to hear from people if they're interested after the workshop.
I agree, Gary, that we should not, I agree that there should be training and increasing competence of people to look into these issues and how to explore, and not only focus on tools to, kind of measure distress or filter distress. So we should have both together and explore deeply and find out what the person is going through, so to improve the competence.
If I can interject for just a quick minute too, in keeping with the time. But I think too, people are looking for very practical, quick, on-the-fly skills, because right now people are barely staying above water, emotionally, spiritually, physically. So there is a new app coming out of Duke that I'm happy to share with Stephen, and I'll send it to you. It's rooted in gratitude, and it's based on science. It's based on great research. And the research also shows that when one can look and find the seeds of gratitude, that it helps to build resiliency and also to help one find meaning and purpose. And I'll share this app with you all, and it's a quick practice rooted in 3 simple things. part of the team is, what is his name from Duke, the palliative care, palliative care specialist. Anyway, I'll share it with you. And it's a really great app that anyone can use, whether they're as a caregiver or care provider, or as well patient and family member.
Great. Thank you,
Can I just interject also that this whole process takes so long? Bereavement takes so much longer than anyone knows. So all of this about meaning or anything like that is going to chop and change over months and years. So it's not a sort of a quick program. I'm sure you all know that, but it is so lengthy.
Great. Thank you, everybody, for those comments. We're going to be wrapping up now, and I wanted to invite those who attended today to come to our session next week. We're going to be shifting these from Fridays to Thursdays for those who observe Friday religiously and don't participate. Anyway, from this going forward, we'll be having these webinars on Thursdays at the same time. So look for those announcements to come out. I want to thank everyone for joining us today, everyone that attended. I'm sorry if we didn't get to your questions. Feel free to go ahead and communicate with us further if you need any further guidance, and be sure to use the resources that are online, both by all the international organizations on their websites. I especially want to ask you to join me in thanking today's faculty, Gary, Chitra, Jenny, Diane, and Patty and Dale, for excellent presentations. On behalf of the global palliative care organizations, this is Stephen Connor signing off and hoping that you stay well. Thanks for joining us.
Thank you all.
Thank you.